commonly what I see in clinical practice is that when we have a superior or a middle cluneal neuralgia, basically neurogenic inflammation of these nerves, patients are usually going to have pain that is not improved with traditional measures. So let's say you go and you have an epidural and it doesn't really help, or you have facet joint injections with cortisone and it doesn't really help, or a sacroiliac joint injection doesn't really help. That's one piece of information. Commonly, if physical therapy is not attuned to these cluneal nerves, then the physical therapy could actually make patients temporarily worse during. And so what I commonly hear is patients tell me that they stopped going to physical therapy because it was making their back pain worse. And part of the reason for that is if physical therapy does not know that these nerves are involved in the patient's pain, then they may be doing certain movements and exercises that actually could be aggravating those nerves. And so that can happen. And as a general rule, when we have neurogenic inflammation like this, we can see that activity actually makes pain worse, and it doesn't get better with more activity. So commonly what we see with like a tendinosis, so like if we talk about the rotator cuff, or even if we have, a little bit of osteoarthritis in the low back, it generally hurts with some movement, but then once you get moving, things kind of loosen up and things feel better. But what we've found with neurogenic inflammation is that doesn't really let up. And so continuous exercise doesn't really give patients the relief that it would in other situations. In terms of movements, one of the big things is that you can have pain with what's called flexion, which is bending forward, and also extension, which is leaning back. And part of the reason that you can have pain with both of these movements is the way that these nerves are set up. So these nerves have to come off of the spinal cord, and then they have to travel through different pathways, through muscles, in between muscles, sometimes through what's called the fibroosseous tunnel, in order to reach the skin. That means that along those paths, you can have different points where there could be compression or friction. And so what we see is that when you bend forward, the space between the outer part of the nerve, basically in the butt, and the spinal cord, that distance increases. And so you can actually have a lengthening of the nerve, which is normal, but if that nerve is inflamed, then you can actually end up with more pain because that stretch on the nerve that's already inflamed causes more inflammation and more pain. And then when we go into extension, or basically arching the back and kind of looking upwards, you can have compression of the muscles because the muscles of the low back need to flex and contract in order to do that movement. What happens is that flexion and contraction of those muscles can actually pinch on nerves as the nerves are either passing in between two muscles or actually through one of the muscles. That compression can therefore cause additional pain, which can therefore result in you not being able to do those movements. Now, with the superior and the middle cluneal neuralgias, we don't always see that it's both. We don't always see both with flexion and extension causing pain, but we commonly see that, and usually we're seeing it obviously with at least one of those, either flexion or extension. Now, in terms of diagnosis, the number one way to diagnosis is with a physical exam, okay? If someone comes to me and, on a comment on social or whatever, and they say, oh, I have low back pain that gets worse when I bend forward, what is it? I don't know. I have to do a physical exam because there's like 7 or 8 different things that could be contributing to those pain. And there's actually way, way, way more, but most of those things are big, scary things that are ruled out, just knowing that the patient's in good health. But the physical exam is needed in order to really determine what structures are contributing to pain. Yes, imaging can be helpful, and you've heard me talk about this before. Yes, imaging can be helpful, but imaging is not going to show us a cluneal neuropathy. It's not going to show us that your superior cluneal nerve is inflamed and firing off extra discharges because it's inflamed, and that is what is sending signals to your brain saying, pain, do something about this. That's not going to show up. And so we have to get our hands on patients to do physical exam maneuvers, to palpate, to move them into positions, to test things in order to really understand what might be going on with their pain. So that is crucial.